We'll talk about metabolic acidosis. So there's metabolic acidosis is divided into anion gap metabolic acidosis and non-anion gap metabolic acidosis. So anion gap metabolic acidosis, you can think about it as mud piles or whatever you want to think about it. But if you can't remember 4 things, there's a problem with you. So instead of remembering the mud piles, just remember 4 things. It's very easy. The mud piles. Just 4 things, Professor. Lactate, BUN, ketones, and ingestions. You can put anything here under ingestions, right? Non-anion gap metabolic acidosis could be diarrhea, something that makes you lose the bicarb. We know the difference between non-anion gap and anion gap, obviously, right? Non-anion gap is just you don't have an acid that is not being measured. Everything is accounted for, but the bicarb level is low. Renal tubular acidosis or acute renal failure in the ICU starts like this, starts at an anion gap and then goes over an anion gap, and then normal saline or any, we call it bicarb free fluid resuscitation. And next number is ureterosigmoidostomy. This is the 4 major ones. Ureterosigmoidostomy is a classic, is a critical care classic. They used to ask it all the time. Now I don't think they ask it anymore because nobody's doing it anymore.
I've seen it twice though with people with a urostomy.
With urostomies, yeah. But I'll tell you the gravity of the situation first. What we were in before and the urostomy is much better now. So ureterosigmoidostomy is basically when they remove the bladder, they would implant if you implant the ureters in the skin, it's going to close, right? Because it's so small. Skin will just make epithelium over it, it's so tiny. So they implanted the ureters in the sigmoid. So the patient pee and poop from the same hole, which is the least of his problems, by the way. The major problem is that the urine will sit there in the sigmoid, and as we talked before, the kidney is so stupid when it comes to chloride and bicarb, right? It's so stupid. It thinks that the chloride is the bicarb and the bicarb is the chloride. So when the high chloride gets absorbed from the urine, then the kidney starts to lose bicarb, and the patient, survives the cancer surgery, but then dies from acidosis. So then they made the new development, which is they make it into an ileal loop. They call it the ileal loop. So they take a piece of the ileum with its blood supply, they implant it as a urostomy, and in the back of it they implant the ureters, and that made it much better. But still, in some cases, there is pouching. It's a bigger piece. There's some problem with drainage or whatever, and then they still have the same problem. The treatment is just to give them bicarb tablets or Bicetran. I don't know what's wrong with bicarb tablets, but I think it gets deactivated in the stomach with the acid or something. It doesn't work for some reason. I don't see bicarb tablets actually doing a good job. Bicetran does a better job, which is citric acid and sodium citrate, which is transformed in the liver into bicarb. So that's it. Let's talk about, notice this, right? So it starts like this, and then move into this. So renal failure can give you both non-anion gap and anion gap acidosis. This is a little bit earlier, and then the BUN starts to rise. All right, let's talk about lactate. So for lactate, there's the old classification was better than the new classification. The old classification is basically lactic acidosis and hyperlactatemia. Right, so either just high lactate or lactic acidosis, lactate combined with acidosis. The new classification is lactic acidosis type 1 and lactic acidosis type 2. I hate this because it implies that the other type also has acidosis, but it doesn't. Right, so the lactic acidosis, the old classification, basically, there's only 2 things. There's low flow states and metformin toxicity. These are the 2 things that will give you lactic acidosis. Everything else, every high lactate that you see, other than these 2 things, you can fit it into the hyperlactatemia thing. So for example, hyperlactatemia, so for example, you know, somebody who didn't put the sample on ice, for example, so the RBCs are making more lactate, or you use the tourniquet. You know how they get the lactate from peripheral veins? When you order it here, what they do is that they put the tourniquet, they put the needle in, they get the CBC and the Chem10 and the VBG and all of this thing, and then they let go of the tourniquet and wait for a period of time. Who knows how much? And then they give you the lactate. So if the lactate, the peripheral lactate doesn't make sense to you, get the ABG, get a arterial lactate or venous lactate, or repeat it, you know, if it doesn't fit with the whole picture.
Yeah.
Right? Also, you know, beriberi or thiamine deficiency, that will give you, you know, high lactate. Also, ethylene glycol. Ethylene glycol will trip the machine, will actually fool the machine into thinking that it is lactate. Like the machine thinks that ethylene glycol is lactate, right? Linazolid can give you high lactate. Albuterol can give you high lactate, right? What else? D-lactatemia. D-lactatemia is the lactate that comes from non-human cells. So human cells make L-lactate, and the tumor cells or bacterial cells make D-lactate. So that's why if you have tumor lysis syndrome, you might have high lactate without acidosis. You might have acidosis for a different reason, but if you have a high lactate without acidosis, that's the tumor cells dying. And if you want to send the D-lactate, it will take a month to come back, but at least you prove the case. The patients with small bowel obstruction, with overgrowth of bacteria, then they also have hyper D-lactatemia. I had a case where there was like 3 intensivists, I swear, 3 intensivists rounding with me. I don't know how we got 3 intensivists rounding with me on rounds by the patient's bedside. But anyway, and all of them were, there was a big dispute about the case, and they all wanted to prove me wrong for some reason. I said, this patient, you know, I was pushing for the patient to kind of survive, is having a good outlook, and they were all saying that this patient, you know, I'm just saving you the details, but all of them saying that the patient is like going, you know, to hell, basically, right? And one of the things that everything looked good except that he has a high lactate, right? So the patient was bilirubin type 2, bilirubin 2. You know, the surgery.
Right?
So they did the stomach surgery. So they removed part of the stomach. So what they do, it was an ulcer surgery. So they remove part of the stomach, and then they take the they can't cut the duodenum, right? Because this is where the pancreatic secretions come in, and the biliary secretions come in, right? So they had to keep the duodenum, but then they cut that piece. They cut past a part of maybe the first part of the duodenum, and then as they're passing, they pass the jejunum like this. So basically, the stomach will pass directly into the jejunum, the food, right? But this pouch from here all the way up to here is not used. The only thing it's used for is just to collect the secretions
It's
from
like
both.
a Whipple, yeah? It's similar to a Whipple, except they're connected more.
The Whipple, yeah, the Whipple, they can connect everything together. I think
Or Roux-en-Y, it's similar to a Roux-en-Y.
Yeah, that's Roux-en-Y.
Yeah, sorry.
So basically what happened is that this, the guy had a lactate of 18. He's totally normal. Nothing is wrong with the guy, right? And he's alkalotic on the gas. So it was like, and they're like, let's do MRI, let's do CAT scan, let's do whatever. I said, this is a blind loop. This is a blind loop right here. All the bacteria here are making lactate, but it's D-lactate. It's not injuring, it's not hurting the patient, it's not doing anything. And of course, we did still the CAT scans and everything because everybody insisted, and nothing is wrong with the patient. Bicarb will increase the lactate. Of course, nobody knows that except me because I give the most bicarbon. I deplete the bicarb out of the state of Massachusetts. So I reached that level, those high, very, very high, super high levels that you can see that the lactate. So what happened with that? So you know when you give lactated drinkers, what does the lactate become in the liver? It becomes bicarb. And so on, and the opposite is true. If you give so much bicarb, the bicarb becomes lactate. But again, it's not acidosis; it's just lactate. Right? All right. And that is it.